Dr. Andrew Kolodny. Even I practiced on that early. Dr. Andrew Kolodny is the co-director of the Opioid Policy Research at the Heller School of Social Policy and Management. His primary area of focus is in the prescription opioid and heroin crisis that really has divested a lot of families and communities across the country. We're all aware of that. He's also the executive director of the Physicians for Responsibility Opioid Prescribing. This is an organization with a mission to reduce morbidity and mortality caused by overscribing. Dr. Kolodny previously served as the chief medical officer for the Phoenix House. The Phoenix House, again, is a national nonprofit addiction treatment agency, and he's also the chair of psychiatrists at a medical center in New York. He has a very long-standing interest in public health. He began his career working for the New York Department of Health and the Mental Hygiene Office as the Executive Deputy Commissioner. So at this time, without further ado, I would like to introduce to some and present to others Dr. Andrew Kolodny.
Thank you. That's okay, I've got it. It's a pleasure to have this opportunity to speak with all of you about the opioid crisis. I've been giving talks about the opioid crisis for maybe about 15 years now. And you'll understand as I go through the talk that although we hear a lot about the opioid crisis today, it's not a new problem. It began about 25 years ago and just steadily got worse. I'd say for the first 10 years that I would talk to an audience about the opioid crisis, what I would try and do is convince people in the audience that we have a serious problem with opioids, and I'd show a lot of data to make the case that we've got a really bad problem and it's getting worse and it's getting worse quickly. I no longer have to give that talk because I think that everybody now knows we have an opioid crisis, and I think the problem became so severe it was impossible for the media, for policymakers, for the public to not notice it anymore. So instead of trying to spend the next hour and a half convincing you that we have a problem with opioids and that we have an opioid crisis, what I will try and do is turn all of you into experts about the opioid crisis so that you'll really understand the problem. I'm going to speak mostly nationally, but what I have to say about the opioid crisis nationally is all true for Louisiana. There are some regional differences which I'll explain. I'm going to show you a lot of graphs. If you're not used to looking at graphs, then it's going to take you a couple of minutes to make sense of the graph. But if you concentrate and if you listen to what I'm saying, if you look carefully at the graph, at the y-axis and the x-axis, it'll all very quickly begin to make sense to you. So if you concentrate during my talk, you'll be rewarded with expertise in the opioid crisis, I promise you. So let me get started. My disclosure statement, I have no financial relationships with any pharmaceutical companies. I think after you hear my talk, you'll understand why no pharmaceutical companies would want a relationship with me. And I do have a disclosure that I've served as an expert witness for states that are suing pharmaceutical companies for causing the opioid crisis. And I think you'll understand after my talk why that litigation makes a lot of sense. So let me start by saying something that should be obvious, but it's not. It's not even obvious to doctors who prescribe opioids. When we talk about drugs like hydrocodone, which is in Vicodin, Lortab, Norco, or drugs like oxycodone, which is in Percocet or OxyContin, or oxymorphone, which is an opana. When we talk about these very commonly prescribed opioids, we are talking about drugs that are literally made from opium. You need opium to make hydrocodone and oxycodone. You start with opium to make them. And what you're doing when you make these drugs is you're actually oxycodone and hydrocodone, another term for them would be semi-synthetic. We all know that synthetic is something completely artificial. Semi-synthetic means you start with something natural to make it. So oxycodone, hydrocodone, these commonly prescribed opioids are semi-synthetic. Heroin is also semi-synthetic. You start with opium to make heroin. Now, why would drug cartels convert opium into heroin? Why wouldn't they just sell the opium or sell the morphine, which exists naturally inside opium? Well, the reason they go to the trouble of converting the opium into heroin is because you're creating a drug that's more potent, a drug that gets into the brain faster. That's why you make semi-synthetic opioids instead of the natural ones. When you make hydrocodone and oxycodone, you're doing the same thing. And something many people don't know is that the effects of the semi-synthetic opioids, whether it's heroin, oxycodone, or hydrocodone, the effects are almost identical. If you give an experienced heroin user an opportunity to take heroin or oxycodone or another opioid and you don't tell them which is which, kind of like a blind taste test, and this was a study they did at Columbia University where they gave experienced heroin users different opioids to try, didn't tell them which was which, and then asked them, which do you like the best? In that study, the oxycodone actually beat out the heroin. Now, what's my point? The point that I'm trying to make is that when we talk about opioid pain medicines, medicines that many of you may have in your medicine chest, when we talk about opioid pain medicines, we are essentially talking about heroin pills. Now, to make such a dramatic statement doesn't mean that doctors should never prescribe them just because they're essentially heroin pills. They are important medicines for easing suffering at the end of life, and if someone's just had major surgery or a serious accident, to use it for a couple of days. But unfortunately, the bulk of the prescribing of opioids in the United States and here in Louisiana, and the bulk of the consumption of opioids is not for end-of-life care or a couple of days after major surgery. The bulk of the prescribing is aggressive and prescribed in ways that it's more likely to harm the patient than help the patient. This is an old slide. The CDC came out with this slide in 2010, so it's almost 10 years old now. And when the CDC came out with this slide, there was about a 3-year lag in the data, so the most current data they had was from 2007. And when they came out with this slide in 2010, the CDC had just started referring to the opioid crisis 10 years ago using the word epidemic. And when the CDC started to use the epidemic term, it got criticized. And the criticism was coming from these groups taking money from drug companies that make opioids. And the pain groups that were taking the money from the drug companies, they said to the CDC, stop calling this an epidemic. It's not an epidemic. You're exaggerating. And if you keep calling it an epidemic, you're going to scare doctors and they'll be afraid to prescribe opioids, and lots of people will have pain that doesn't get treated. So stop calling it an epidemic. The CDC responded to the critics by saying, we're the CDC. We don't use the term epidemic lightly. This is an epidemic. And then they went even further. They said, not only is this an epidemic, this is the worst drug addiction epidemic in United States history. And that's the point that they're making with this graph. If you look at the blue bars, those are the columns there. That's the rate of drug overdose death. And you see that box that says heroin? That's the heroin epidemic of the 1970s. And if you look at the box that says cocaine, that's the crack cocaine epidemic of the late 80s, early 1990s. And what they were showing us with this slide is that people were dying from drug overdoses back in 2007 at a much higher rate than they were dying during the height of those two previous epidemics. Even combining them, there were more people dying of drug overdose deaths. So I mentioned this is an old slide. I want you to understand what's happened since 2007, which is the last blue bar that you see there. In 2008, we broke a record and overdose deaths went up again. In 2009, it went up, 2010, 2011, 12, 13, 14, 15, 16, 17. By 2017, there were 72,000 Americans dying of drug overdoses each year. Just to put that number into perspective, the number of Americans who died fighting in Vietnam during that 20-year conflict was about 44,000 Americans. Over the 20 years of fighting in Vietnam, 44,000, and in 1 year we lose 72,000 Americans to drug overdose deaths. 2018 was unique because it's the first time in about 25 years that overdose deaths didn't go up. We didn't break the record in 2018. It actually came down a little bit, which is a very positive sign that maybe we're beginning to turn the corner on this crisis. And toward the end of my talk, I'll go over why we might be making some progress finally. So the previous graph was showing you death from drug overdose, but it wasn't showing you the specific drugs that are involved in those deaths. This graph is showing you what the picture looked like up until 2010. It changed after 2010. That'll be my next slide. Up until 2010, what caused the deaths to rise was almost entirely due to the red line. And what's the red line there? Correct. Heroin, you'll see, is at the bottom there in green. You see cocaine went up and came down. Cocaine has kind of done that over the years. It goes up and down a little bit. The gray line, that's benzodiazepines. That's drugs like Xanax, Valium, clonazepam or Klonopin. That's what the gray line is, and the trend there is concerning. It's another class of drug that doctors write too many prescriptions for. But clearly what drove the increase was the red line, prescription opioids. Now, after 2010, the picture changes. Here on this graph, the green line is the total opioid overdose deaths. The purple line, which is the next line down, that's the prescription opioids. And you could see here that up until 2010, what really caused the increase was that purple line. But you see, starting around 2011, the purple line's not going up so quickly. And you start to see the orange line go up, which says heroin. And then you see that I can't really see what the color is. Is it black? Black. Then it says synthetic opioids. Anybody know, by the way, what that black line that says synthetic opioids primarily is? What drug that is? Fentanyl, thank you. So now, because of the trends on this graph, you have a flattening of deaths from prescription opioids, and then you have this increase in heroin deaths, and then you have this increase in illicit fentanyl deaths. Because of these trends, many people are looking at this graph and explaining it in a way that's incorrect. The popular explanation for what you're looking at here is that, well, what happened is it started with the prescription opioids, and then the drug users switched over from prescription opioids to heroin, and then they switched over to fentanyl, and because they switched from, to more dangerous opioids, the deaths that green line just got even worse. That story is partly correct, but it's also partly wrong. The part of that story that you're hearing that's correct is the switching part from prescription opioids to heroin. It is true that the vast majority of people who started to use heroin after 1995 were first addicted to prescription opioids and they switched to the heroin. That part of the story is true. But it's not true that the switching happens suddenly in 2011 when the orange line goes up. And it's also not true that we have this homogenous group of drug users who kind of keep switching from one drug to another. If you just look at the death data, this is death data, it's not telling you what drugs people are using, it's showing you what drugs are killing people. If you just look at the death data, it kind of looks like that's what's happening, but it really isn't. I'll show you what I'm talking about. For one thing, fentanyl is not affecting the entire country. Fentanyl is really affecting the eastern half of the United States. There are many states where the prescription opioids are still killing more people than heroin or fentanyl. So the geographic differences are important, but if you just talk about these drug users moving from one to another, you're missing these important geographic differences. There are other important differences in race. For example, the geographic area in the United States that's been hit hardest with fentanyl, inner city Washington, D.C. That's where fentanyl has taken the greatest death toll. And that's an area where you have this aging group of survivors from the heroin epidemic of the 1970s. The heroin epidemic of the 1970s disproportionately hit inner city communities. Black communities got hit very hard with heroin in the 1970s. And survivors of that epidemic who are now in their 50s and 60s and 70s, who still struggle with their heroin addiction even though they're older, because heroin addiction is something that really sticks with many people for the rest of their lives, they're the group that's been hit very hard with heroin, and a lot of people miss that in this whole story. And inner city Washington, D.C. has been clobbered with fentanyl. These men, mostly men, not that many women were affected by the heroin epidemic in the 1970s. These men who managed to beat the odds for 40 or 50 years with their heroin addiction, when HIV came and killed tens of thousands of injection drug users, they survived that. They've seen many of their friends die of overdoses over the years. They made it to their 60s. But with fentanyl emerging and the heroin supply becoming so dangerous, one slip is all it takes. Now, I want to explain this. This is one of those graphs that you have to concentrate to be. It doesn't make sense right away. The graph on the right is black people. The graph on the left is white people. The color of the lines are the age groups. I want you to start by looking at the red line. That's people ages 20 to 34 years old. Now, I want you to start by looking at blacks, 20 to 34 years old. And you'll see heroin use is actually going down. You see that if you look on the graph on the right, black people, you look at the red line, 20 to 34 years old, you see decreasing use of heroin among young blacks. That's been a trend that's been in place for well over 30 years. Crack cocaine as well has been decreasing among young blacks. If you go into communities that were hit very hard with crack cocaine, you'll still find crack cocaine users. But they're not young people. They're an aging group of people still struggling with their crack cocaine addiction. Anybody ever hear the slogan, crack is whack? That wasn't a slogan that the health department invented. That was kids in communities that were hit very hard with crack cocaine who said, crack is whack. They saw what it did to their communities, to their families, and they started to stay away from it. Among young kids in inner city communities, there's often very heavy marijuana smoking, which is its own problem, but they did start to stay away from heroin and crack cocaine. Now, I want you to look at the graph on the left. That's white people. And I want you to look at the red line. Whites, ages 20 to 34. What do you see? Rising use of heroin. And it doesn't begin in 2011 when the deaths started to go up. It began much earlier. The graph begins in 2003, but young white people in the United States start using heroin at a very fast rate. It really begins late 90s, early 2000s. What's going on with these young whites, 20 to 34 years old, with this rising use of heroin? Well, as I mentioned, these are young white people who switched to heroin after getting addicted to prescription opioids. And how did they get addicted to prescription opioids? Well, they got addicted to prescription opioids pretty much in one of three different ways. They got addicted to prescription opioids because they were taking them for fun. They did that a little too much and they got hooked. Or they got addicted to prescription opioids because they had a major medical problem. A doctor gave them a very aggressive prescription and they got addicted to their prescription. Another term for that is iatrogenic addiction caused by medical treatment. And then the third way that these young people got addicted to prescription opioids, and I think it actually may be the most common way that people get addicted, it's almost a combination of those first two ways. It's a young person with a brief medical exposure, wisdom teeth come out, sports injury, something minor. They don't get addicted from that prescription, but they're basically getting their first taste of the drug from a doctor or a dentist. And they may have liked the effect. They're certainly not afraid of it because the doctor prescribed it to them and it didn't hurt them. And at some point after that brief medical exposure, and it could be right away with the leftover pills, or it could be 3 years later, they bump into a friend who's got a pill bottle full and they say, oh yeah, I remember those, I like those, I'll have some. And there are a few studies now that show us that if you expose an individual as a child to opioids for a medical problem, when they become a teenager or a young adult, they're much more likely to use it non-medically. So these are young people who become opioid addicted. Now, once they're addicted, once anybody gets addicted to opioids, you're not doing it for fun. You're not doing it for you because you like the effect. Once you're addicted, you have to keep doing it to avoid feeling very sick. And when I say sick, I'm not just talking about the flu-like symptoms of opioid withdrawal that you've probably heard of. The reason people do such desperate things to maintain their opioid supply when they're going into withdrawal isn't that they're afraid to feel like the flu. It's not the physical symptoms of the withdrawal that make people act so desperately. It's actually the psychological symptoms. When people are going into withdrawal, there's a region of the brain that makes us feel anxious, that begins to start firing rapidly. And as that anxiety starts setting in, it's kind of like a panic attack. But if anyone's ever experienced a panic attack, they're pretty awful, but they get better quickly on their own. With opioid withdrawal, they just keep getting worse and worse. There's what's been described as a sense of impending doom. People feel like they're going to die when they go into withdrawal. That's why they do such desperate things. So you've got these young people who become opioid addicted. They now have to maintain their opioid supply. They have a hard time doing that visiting doctors. Now, it isn't that doctors and dentists are uncomfortable giving young people lots of opioids. Unfortunately, we're too comfortable doing that. But doctors don't like to give healthy-looking 25-year-olds a large quantity of pills on a monthly basis for chronic pain. Unless the doctor's a drug dealer, that's going to make them uncomfortable. And so these young people have a hard time maintaining their supply visiting doctors, so where do? They go onto the black market, onto the street. The pills have been very expensive, and they still are very expensive on the street. Does anybody know what an 80 milligram OxyContin was selling for back in 2003? Somebody said 20 bucks. Nope. 80 bucks. Who said that? Okay, I'm not going to ask you how you know that. But So he's right. It's $1 a milligram. And they didn't suddenly become expensive on the street in 2011 in the context of a so-called crackdown on pills. There hasn't been a crackdown on the pills, which I'll show you in a moment. They've always been expensive on the black market. $80 a pill. If you're hooked on these pills and you were in a region of the country where there was heroin, you would switch because it was much cheaper and produces the same effect. And something that's happened steadily, not suddenly in 2011, but steadily from the beginning of the prescription opioid crisis, heroin starts moving into more parts of the country where it wasn't previously available to meet the demand for it by this growing number of young people who got addicted to the pills. You have these quaint towns in Vermont that never had heroin, where it's now flooded with heroin. Okay. Now I want you to look at the green line on the left. White people 45 and up. Middle-aged and older white people. Have middle-aged white people been spared from the opioid epidemic? You don't see rising use of heroin. Does that mean middle-aged whites in the United States have been spared from the epidemic? I hear some people saying no. You're correct. They haven't been spared. In fact, middle-aged whites in the U.S. have been one of the groups hit hardest by the opioid crisis. So why no rising use of heroin among middle-aged whites? Well, this is a group that doesn't need to switch to heroin. It's a group that doesn't have a hard time maintaining an opioid supply, visiting doctors. And so these are middle-aged people who became opioid addicted almost entirely through medical treatment. Some for a chronic pain problem, but many, they had a surgical procedure or an injury, they were prescribed opioids aggressively, and they never came off. 2-3 years later, they're still on opioids, and the doctor has diagnosed them, well, they need the opioids for chronic pain, or they'll tell you, I'm a chronic pain patient. Many will be very adamant that they're not addicted because they're getting their pills from a doctor. And even when the doctor starts to get nervous, let's say the patient is coming in early having run out, the patient will typically say, well, I took extra pills because my pain got worse. The doctor doesn't want to put a label like addiction on the patient. The patient is saying, well, their pain has gotten worse, that's why they're taking extra opioids. When these patients get referred anywhere, it's generally not for addiction treatment, it's to pain management doctors. And when they get to that pain management doctor, it's hit or miss. They might, if they're lucky, land on a pain management doctor that's going to try and address their pain problems in ways without opioids and try and get them off the pills. But they may also land on a pain management doctor that has no problems going even higher and higher on the doses of opioids. Now, something many people don't realize is before the heroin supply became so dangerous with fentanyl in it, when you looked at where we were seeing more of the deaths, in the pain patients who get pills easily from doctors, the older group, versus the young group switching to heroin, a lot of people might think you'd see more deaths in the group switching to heroin because heroin's more dangerous than the pills. But no, actually before fentanyl emerged, we were seeing more deaths in the group that gets pills more easily from doctors. You see that on this graph here. The light blue on this graph are opioid pain reliever deaths from the pills. The dark blue is death from heroin. And you could see more of the deaths were from the pills than from heroin, and the age group with the most deaths was that middle-aged group. Now, let me summarize what I've said so far, and then I'm going to move on. We have, roughly speaking, 3 groups of opioid-addicted Americans. We have this group I've just told you about, this young white group. They're in their 20s to their early 40s. They get addicted to the pills, and they've been switching to heroin. Then you have this middle-aged white group that has been getting addicted to the pills and doesn't need to switch to heroin. And then you have this third group, which is mostly non-white, survivors of a previous epidemic that started with heroin, didn't switch to heroin. And in this first group and in this third group, and in the eastern half of the United States, the death toll the past few years has been like nothing we have ever seen before. Just a soaring increase in deaths in that first group and the third group. Whereas in that middle group, we're doing a little bit better because doctors have started to prescribe more cautiously. We're doing a little bit better. We still have a long way to go. So these are headlines I took off of the internet. They were in news stories. These were in news stories about the opioid crisis. And you'll hear the term opioid crisis used quite a bit. But what is the opioid crisis? What is the right way to frame the opioid crisis? Or what's the wrong way to frame it? The wrong way to frame the opioid crisis, and unfortunately it's often described this way, the wrong way to frame the problem is as an epidemic of drug abuse. The wrong way to frame it is as an epidemic of heroin abuse or prescription drug abuse. Abuse is the wrong word. This is not an epidemic of drug abuse. When you frame it as an epidemic of drug abuse, what I think you're suggesting is that the problem is a lot of people out there behaving badly, taking dangerous drugs because it feels good, and they're accidentally killing themselves. That's not what's going on. This is not an epidemic of people saying, gee, injecting fentanyl seems like a fun way to spend a Friday night. And that's not what's happening. The correct way to frame the problem is as an epidemic of opioid addiction. Now, it is true that some people became addicted because they were abusing the drugs. They were taking them for fun, and that's how they got addicted. That's true. Other people got addicted taking pills prescribed to them by doctors. But regardless of how you got addicted, once you're addicted, fun is not why you're continuing to use this. As I explained, what drives continued use more than anything else once you're addicted is that without the drug, you feel awful. The correct way to frame the problem is as an epidemic of opioid addiction. And when you frame it that way, what you're saying is that the reason that the United States and Louisiana are experiencing record high rates of death from opioid overdose, the reason we're seeing heroin and fentanyl flood into communities across the United States, the reason we've seen a soaring increase in infants born dependent on opioids, children winding up in the foster care system, outbreaks of injection-related infectious diseases, impact on the workforce. The driver behind all of these health and social problems that we refer to as the opioid crisis has been a very sharp increase in the number of Americans suffering from the condition of opioid addiction. A 900% increase in the number of Americans addicted to opioids from 1997 to 2011. And I'm going to show you the epidemic occurring. So this is 1999. The epidemic began in 1996, so this is 3 years into the epidemic. You'll understand in a moment why I say the epidemic began in 1996. So just for now, take my word for it. So this is 3 years into the epidemic. And the states on the map that show up as either red or maroon, those are the states that have the highest rate of people seeking treatment for addiction to prescription opioids at state-licensed drug and alcohol treatment programs. So the states with the highest rate show up as red or maroon. I want you to see what happens to the color of the map as we go forward in time by 2-year increments. So this is 1999, 2001, 2003, 2005, 2007, and 2009. what you can see is that in just about every state in the country, we saw a very sharp increase in the number of Americans addicted to opioids. And when you have a sharp increase in a disease over a short period of time, that is the definition of an epidemic. Now, what's caused the epidemic? What caused the maps to turn red? What's caused this soaring increase in death from overdose? What is the cause of our opioid addiction epidemic? Well, I think one of the first and best answers to that question came from a medical director at the CDC's Injury Prevention Center, Dr. Len Palazzi. Dr. Len Palazzi worked in the Injury Prevention Center for the CDC. He was the guy at the CDC responsible for deaths from accidents in the United States. And for many years, for decades, if you died from an accident in the United States, overwhelmingly that meant you died from a car crash. The vast majority of accidental deaths were car crash deaths. In the early 2000s, Dr. Palazzi starts to see something happening. He starts to see that, gee, so many Americans now are dying of poisoning. If the trend continues, we're going to have more Americans dying from poisoning than dying from car crashes. He has to figure this out. And by the way, the trend did continue. And more Americans today die from a drug overdose than from a car crash. More Americans die from an opioid overdose than from a car crash. But in the early 2000s, he starts to see this trend that poisoning deaths are taking off. Well, it took Len a few minutes, really, to figure out that these poisoning deaths, those were drug overdose deaths from prescription opioids. He knew that because the CDC had the death certificate data. So the next thing Len had to figure out is, well, why is there this sudden rising, soaring increase in death from prescription opioids? What is causing this? To answer that question, he did something pretty neat, and he did it on this graph here. What he did was he charted out on the graph in orange the deaths involving prescription opioids. And then in yellow, on the same graph, he charted out sales for prescription opioids. And what does that really mean? That means prescriptions for prescription opioids. And what did he show us with this graph? He showed us that as the prescribing of opioids went up, the deaths went up directly in parallel with the rise in the prescribing. What he argued in a paper that he published was that this epidemic has been caused by the medical community. That as we started to become much more aggressive in our prescribing of opioids, as the prescribing went up, the deaths went up right along with the increase in the prescribing. Now, that was old. This is a little more current. This has been one of the CDC's chief speaking points for many years. The green line on this graph represents consumption of opioids in the United States. The red line represents the deaths from prescription opioids, and the blue line represents addiction to prescription opioids. And the CDC's point, and when they show this to doctors, their message is that the rise in the green line is causing the rise in the red line and the blue line, and that we may not be able to bring this problem under control until the green line starts to come down, until doctors start to prescribe much more cautiously. I can tell you that drug companies that make opioids don't agree with the CDC. And I'm not just saying that. In fact, in the first few years as those three lines were going up together, the drug companies were paying scientists to publish papers in medical journals saying that this isn't happening. There were articles published in JAMA, one of the best medical journals, saying that the prescribing is going up, but there is no evidence of any adverse public health problems associated with the rise in the prescribing. In other words, doctors are prescribing more and there are no problems. We can have our cake and eat it too. By around 2009, they stopped denying that these three lines were going up together. They started to say something different. They started to acknowledge, yes, there have been problems associated with the rise in the prescribing, but we've got an answer. We need doctors to prescribe pills that are hard to crush, so-called abuse deterrent formulations. If we make the pills harder to crush so people can't abuse them, and if we teach doctors to just monitor their patients a little bit better, select their patients a little more carefully, then we can have our cake and eat it too. The prescribing, the green line can keep going up, and we'll be able to make the red line and the blue line go down. Unfortunately, that won't work. Drug companies haven't just been saying these things. They've been putting their money where their mouth is. So this is data that came from an investigation by the Associated Press and the Center for Public Integrity. What they looked at was the money that the drug companies and the companies that make opioids and the companies that distribute the opioids, they looked at how much they were spending trying to block the federal government or state governments from imposing any kind of restrictions. They looked at the money that was being spent to keep the green line from coming down. What they found was that over a 10-year period, they had spent $880 million blocking efforts to produce more cautious prescribing of opioids, that they had spent 8 times more than the gun lobby had spent trying to block rules that would make guns harder to get. Now, prescribing has started to come down, finally. The blue line on this graph represents prescribing of oxycodone or consumption of oxycodone in the United States. And you can see we peak around 2011, 2012, and it's come down. You see that red line at the bottom? That's prescribing of oxycodone in Europe. We have a very long way to go before we get to rational levels of prescribing. This graph ends in 2015, and it was just oxycodone. This is all opioids, and it's a little more current. And what you see is that we peak in around 2011, 2012, that the trend is moving in the right direction. But even with the most ambitious projection, which is the green area in the box to the right, even with the most ambitious projections, by 2023, we'll still be almost double where we were before we had the epidemic in the early 90s. So again, a lot of work has to be done to try and promote more cautious prescribing. And I can tell you, the drug companies are really working very hard to try and preserve the status quo. They don't want to see prescribing coming down anymore. So, okay, I've explained that the opioid crisis is an epidemic of opioid addiction. I've explained that the reason we have this epidemic is the medical community started to prescribe opioids so aggressively. Now I want to explain to you why we started to prescribe opioids so aggressively. What caused this change in medical practice? Well, there's a really good clue on this graph, and this is New York State data, but I could tell you that the graphs for every state basically look identical. You can see on this graph the exact year that the prescribing of oxycodone in the United States takes off. Now, you may know that 1996 was the first year that OxyContin was on the market. And so you could look at this graph and you could explain it by saying, okay, what you're looking at here is the impact of the introduction of OxyContin. And so that before 1996, that's Percocet, which has oxycodone in it, small amount of oxycodone mixed with Tylenol. And then in 1996, you have the introduction of OxyContin, which packs a whopping dose of oxycodone in it. And it's being aggressively marketed and promoted and prescribed. So you could explain this graph by saying you're looking at the impact of OxyContin. And if you explain this graph that way, you would be correct. But take a look at hydrocodone. You see a pretty similar trend. There was a little bit of an increase in hydrocodone. That's the drug that's in Vicodin, Lortab, Norco. A little bit of an increase before 1996. But you also see that 1996 is the year that the hydrocodone took off. If I put up a slide for morphine, you would see 1996 is the year that morphine goes up. If I put up the slide for the fentanyl patch, you'd see 1996 is the year that it takes off. If you look at any opioid that was on the market before 1996, you'll see that 1996 is the year that the prescribing explodes. And it begs the question, what happened in 1996 that caused the change in the culture of opioid prescribing in the United States? And I think the best answer to that question can be found in a government report by an agency called the GAO. And the GAO did a report that looked at the marketing of OxyContin the year it hit the market, and basically the first 6 years of the release of OxyContin. This is a graph from that report. And the point that they're making with this graph, they were showing you that Purdue Pharma spent much more than had been spent previously in promoting opioids when they introduced OxyContin. So that tall light gray bar is the first 6 years of the release of OxyContin, and it's compared to MS-Contin, another opioid, and Duragesic, the fentanyl patch. And by year 5, Purdue Pharma was spending $30 million a year promoting OxyContin. Now, you could look at this graph, you could hear what I'm saying, and you could ask a really good question. You could ask, well, if the GAO is correct, if this was about Purdue Pharma and their marketing of OxyContin, why did Vicodin go up? Why did morphine go up? Why wasn't the increase limited to oxycodone if this was all about the aggressive marketing of an oxycodone-containing product? They answered the question in the report. What they really point out is that the bulk of what Purdue Pharma was doing when it introduced OxyContin was to get the medical community to feel comfortable with opioids as a class of drug. A lot of what they were doing was unbranded. Yes, they were spending $30 million promoting their new branded product, but they were also working very hard to make doctors feel much more comfortable with opioids as a class of drug, which is why all of the opioids went up. Now, why did Purdue Pharma want doctors to feel so comfortable with, why were they doing this? Well, they're introducing OxyContin. What do they want with OxyContin? They want financial success, and you can't blame them for that. The manufacturer of any product wants financial success. Purdue wanted a blockbuster drug. In the pharmaceutical industry, a blockbuster drug is a drug that brings in more than $1 billion a year in sales. By year 5, they had achieved blockbuster status with OxyContin. They wanted a blockbuster drug. But it would have been very hard for them to do that with OxyContin if OxyContin had only been prescribed to people near the end of life with cancer, which is a good indication for extended release oxycodone, people dying from cancer. You can't turn a drug like that into a blockbuster because the patients won't be on your drug for very long if they're near the end of life. And end-of-life cancer pain is not that common a condition. The way you can have a blockbuster drug is if doctors prescribe it for common problems and long-term problems. And if it's a drug that's difficult to stop taking, you got a pretty good recipe for a blockbuster. But Purdue Pharma had a problem on their hands. in trying to achieve blockbuster status. And they knew this because they had done focus groups with doctors to inform their marketing strategies. They knew that in the early 90s, doctors would be reluctant to prescribe OxyContin. In the focus groups that they did in the early 90s, they put doctors around a table and they'd say to the doctor, "Doctor, would you prescribe a drug like OxyContin? Would you prescribe opioids for your patients who have chronic low back pain or fibromyalgia or chronic headache?" And when they asked the doctors these questions in the early 1990s, the doctors would answer by saying no. And they said, well, doctor, why wouldn't you prescribe opioids for low back pain? The doctors would say, well, I'd be concerned that if I gave lots of my patients a highly addictive drug and prescribed it long term, lots of my patients might get addicted. I would be worried about the tolerance to the pain relieving effect. In order for the patient to continue getting pain relief if they're taking it long term, the doses would have to keep getting higher and higher. And as it got higher and higher, it would get more dangerous and the patient's function would start to decline. I would be worried about the physiological dependence that sets in, so that even if the patient didn't clearly get addicted, it might be very hard to ever get them off the drug. What Purdue Pharma did was to reframe very good reasons for being cautious with opioids as barriers to compassionate pain care. And in 20,000 continuing medical education programs, CME programs, 20,000 that were done during the first 6 years of the release of OxyContin, these were some of the chief educational messages. Doctors start hearing that patients are suffering needlessly because we've been too stingy with these drugs, that we have an irrational fear of opioids, that we're suffering from opiophobia, and that patients can't get opioids because doctors have an overblown fear of addiction. We start hearing that patients with legitimate pain very rarely ever get addicted, that much less than 1% of patients get addicted to opioids. We start hearing, don't worry about the dependence that sets in. Patients can come off easily when the time comes, and that this is safe and effective for chronic pain. None of this was true. Safe and effective for chronic pain, we know, especially with data from workers' comp, if you treat an injured worker's chronic pain with long-term opioids, that worker is far less likely to ever go back to work again compared to any other intervention you could have offered them for their chronic pain. We know that they're not safe and effective for the vast majority of patients with chronic pain. They can even make pain worse. It's a phenomenon. Anybody know what that's called, where opioids make pain worse? I'm sorry? No, the term, it's called hyperalgesia, where opioids actually make pain worse. None of this was true. Now, some of you are probably sitting there saying, I don't know, this is hard to believe. You all, doctors, are supposed to be smart. You fell for this? You know, and I can understand your skepticism. But what you have to understand is that we weren't just hearing these messages from the attractive drug reps who visit us in our offices that work for the drug companies. If it's a male doctor, they send in these very attractive young women. If it's a female doctor, they send in handsome young men to talk about these products, and they're trained in how to flatter the doctor. Dr. Kolodny, have you lost weight? You look really, and if it was just the drug reps that come and visit us, telling us, don't worry, opioids are not addictive, we would have been less gullible. But it wasn't just the drug reps. We were hearing these messages from pain specialists, eminent in the field of pain medicine. We were hearing it from our professional societies. We were hearing it from our hospitals, even state medical boards. From every direction, you're hearing that if you're an enlightened doctor in the know, you're going to be different from those stingy, puritanical doctors of the past. You'll understand that opioids are a gift from Mother Nature and should be used much more for just about any complaint of pain. The campaign that was launched was multifaceted. It involved the creation of pain patient groups that were meant to look like grassroots organizations of pain patients demanding better access to treatment for pain. But these were not grassroots groups. They were artificially created by the industry. They weren't grassroots groups. They were AstroTurf groups. And the professional organizations, the American Academy of Pain Medicine, the American Pain Society, which came out with the Pain is the Fifth Vital Sign campaign, which the Joint Commission, which sets the rules for hospitals, adopted the campaign and sets rules making doctors check patients constantly in the hospital for pain. Have any of you been in a hospital or visited a doctor's office where you're shown the smiley faces and the frowny faces and you're constantly asked about pain? I see a lot of you nodding. All of that stemmed from this campaign. And when the Joint Commission came up with those rules for the hospitals, they had a financial relationship with Purdue Pharma as they were doing this. Now, I don't want you to get the idea that this was all about drug companies stuffing money in people's pockets and saying, here are the lies that we want you to tell. It really wasn't like that. Certainly they were stuffing a lot of money in people's pockets, but a lot of the folks who were pushing these messages had really, it was like they really believed it. And a lot of the classes that were being taught to doctors with these messages, the doctor giving the class, many of the doctors were paid by Purdue Pharma, and other drug companies started to do this, but a lot of these classes were taught by doctors who weren't getting paid, but they had really all come to believe this. It was almost like a religious like fervor around the idea that patients are suffering because we're not prescribing enough opioids. State medical boards. State medical boards are the state agency that are supposed to protect the public from a doctor who might be prescribing drugs recklessly. The state medical boards start hearing from their trade association, the Federation of State Medical Boards, they start hearing that there's a chilling effect in America. The state medical boards start hearing that patients are suffering across the country because doctors are worried that if they prescribe opioids for their back pain patients, they're going to get sanctioned. They're going to lose their license. You state medical boards, you're part of the problem of untreated pain in America. The state medical boards fell for it. They changed their policies across the country. Doctors now get issued new medical board policies that say, we will not sanction you based on the quantity of pills or the doses that you give out, but we will sanction you for undertreatment of pain with opioids. So the kind of things that they really thought of in this campaign were brilliant. This is a photograph I took a few years ago, actually quite a while ago, 2007. This was a pain conference in New York City. And there's, just like for today, there's an exhibit hall. In the exhibit hall, the drug companies had their tables. This was the Purdue Pharma table. They were giving out the materials to doctors about how to help your hospital become compliant with the new Joint Commission rules. Purdue was giving this out. Okay, so I mentioned that doctors were taught that the risk of addiction, if you put a patient on long-term opioids, was much less than 1%. That was the statistic. It was used in lectures, journal articles, textbooks. Much less than 1% of patients who get put on opioids long-term get addicted. That was the statistic. Now, I want you to imagine for a moment that you're a young doctor, you're recently out of your training, and you're reviewing a chapter in a textbook, you're reading the chapter, and you come across this statistic. Much less than 1% of patients get addicted when they're put on long-term opioids. And you read that sentence, you read it again because it strikes you as strange. You say to yourself, how can you put people on a drug? You remember that molecule from your medical school pharmacology, that you know that the heroin molecule and the oxycodone molecule are almost identical, you're saying to yourself, how could you put people on a drug just like heroin long term and much less than 1% will get addicted? It just strikes you as strange. So what do? You turn to the back of the chapter in the textbook because you want to see the reference, the citation for this statistic. And what do you see when you look at the back of the chapter? Porter and Jick, Addiction Rare in Patients Treated with Narcotics, New England Journal of Medicine, 1980. It's in the late 90s, early 2000s. Everybody's citing this as proof that you don't have to worry about getting your patients addicted. Now you look at that, it looks pretty good. New England Journal of Medicine, that's one of our best medical journals. The title looks pretty good. Maybe you'd stop there and say, well, I guess it's true. But let's say you really kind of want to know what they did in that study. So what do? You go to the computer, you go to a website called PubMed. You figure I'll read the abstract, the summary of the article, because I just want to see what they did in it. So you go to PubMed, you type this in, addiction rare patients, you put the whole thing into PubMed. Nothing comes up. Strange. You type it in again. Nothing comes up. You're thinking, well, maybe PubMed doesn't go back to 1980. Maybe it's too old for PubMed. But that's not it. PubMed goes back way older than 1980. Maybe you'd stop there, but maybe you say, I really want to know what they did in this study, and I can't get it on PubMed, so you make your way to the medical library. You pull out the 1980 volume of the New England Journal of Medicine. You open it up. What you would find out is that what everybody was citing as proof that you didn't need to worry about getting your patients addicted wasn't actually a peer-reviewed journal article. It was a one-paragraph letter to the editor. This is the whole thing. That's why there was no summary of it in PubMed. This is the entire thing. This is Porter and Jick. It's a one-paragraph letter to the editor describing a chart review study where they went through charts of 11,882 patients who were hospitalized, and while in a hospital bed had received morphine or Demerol or some other opioid while in a hospital bed, and they only found 4 charts out of 11,882 where a nurse or a doctor wrote in the chart that a patient suddenly appeared drug-seeking after getting morphine or something like that in the hospital. This, of course, tells you nothing about the risk of getting addicted when you put somebody on long-term opioids. But this is what was used over and over again, cited hundreds of times, even referred to as a landmark study that proved we didn't have to worry about getting our patients addicted. Now, fortunately, the medical community is beginning to hear that these are not good drugs for daily long-term use. The federal government a few years ago sponsored a review of all of the published medical research on using opioids long-term for chronic pain. And highlighted in yellow there is the conclusion of the review when they looked at all of the published research. What they found after looking at all of the research is, and it says it right there, that evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. Evidence supports a dose-dependent risk for serious harms. What are they saying? They're saying we looked at all of the available research. We can't find evidence that putting people on daily round-the-clock long-term opioids helps people. We did find evidence that it's dangerous, and the higher the dose, the more dangerous it is. I want you to think about that for a second. And think about any kind of medical intervention, like a surgical intervention, anything that a doctor might do. If a doctor doesn't have evidence that a medical intervention is going to help a patient, but they have evidence that it's dangerous, those are medical interventions that we should prescribe rarely. But today, opioids are still routinely prescribed for chronic pain. Now, I've talked a fair amount about using opioids long-term for chronic pain, but it's not just the long-term prescriptions that we have to worry about. This is a graph from a study that the CDC published where they looked at characteristics of a first-time prescription, a prescription for somebody who may have had an injury or just had surgery. And what they found in this study was that the more aggressive that prescription was for that first-time prescription, the greater the chances were that somebody would still be on an opioid a year later. If you take an opioid every day for 10 days, 1 in 5 patients are still on an opioid a year later. Take an opioid every day for 30 days, 40% of patients were still on an opioid 1 year later. These are drugs where when people start taking them, it can be very difficult to come off, because once you try and stop, a symptom of withdrawal is worsening of pain. So people feel like their pain isn't getting better and they keep taking it. We can be a lot more cautious with opioids. This was a study where they looked at people who came into emergency rooms who had a fracture, who broke a bone. Breaking a bone is painful. They came into an emergency room with a broken bone, and one group of patients were given opioids, another group were given basically Advil plus Tylenol. And they didn't tell the doctors or the patients who was getting which. But then they looked at the end at the pain control. What they found was that the group that didn't get the opioids had just as good pain control as the group that got the opioids. Advil plus Tylenol, you can take them together because they work differently. The pain control was just as good, and the patients had less side effects. So even for many acute pain problems, you really don't need to take an opioid. In the United States, when kids have their wisdom teeth out, we routinely give out opioids. Other countries don't do that. You don't have to give kids opioids for wisdom teeth. How do we bring our opioid addiction epidemic to an end? Well, the response to our opioid addiction epidemic is similar to what you would need to do about almost any disease epidemic. Think about what you would do if there was an Ebola outbreak here in Shreveport. Let's say you were tapped and asked to, okay, you're in charge, we've got an Ebola outbreak here, help us figure out what to do. If you stopped and thought for 5 minutes what you would do about an Ebola outbreak, you'd probably come up with the main strategies. You would come up with 2 things, I think. You'd say, okay, here's what we need to do. We need to contain the problem so less people catch the infection. And we have to see that the people who have the infection get treated for it so it doesn't kill them. That's basically the same strategy that we need for our opioid addiction epidemic. We have to prevent more Americans from getting opioid addicted, and we have to see that the people who are addicted receive effective treatment so that it doesn't kill them. Now, when it comes to preventing opioid addiction, there's a lot that can be gained from informing the public about the risks of opioids. There's a lot that can be done through drug prevention organizations that will be very helpful. But I think even more helpful is changing prescribing practices. To prevent opioid addiction more than anything else, we have to get doctors, dentists, nurse practitioners, physician's assistants to prescribe opioids much more cautiously so that they don't addict their patients and so that we don't stock medicine chests with a highly addictive drug where family members can get addicted. We have to treat the people who are addicted, and reducing supply. A lot of people, when they hear reduced supply, they think about the war on drugs, which rightly has a bad reputation because it contributed to mass incarceration. And if you think about our past addiction epidemics, particularly the addiction epidemics that hit non-white groups hard. If you think about the crack cocaine epidemic in the late 80s, early 90s, what was the response from policymakers to that epidemic? It was a message that we could potentially arrest our way out of it. You don't hear that so much anymore. Even from conservative politicians today, when they talk about the opioid crisis, they start by saying we can't arrest our way out of this problem. We have to see that people who are addicted get treated for their condition. It's great that we're hearing it now. It's too bad we didn't hear it then. So the war on drugs rightly has a bad reputation, but there is a role for law enforcement. You do want it to be harder for people to buy heroin on the street or walk into a pill mill doctor. Because if you want people who are addicted to seek treatment, the treatment has to be easier and less expensive to access than it is to buy a bag of dope. Why, if it's this easy, how come the epidemic got worse for 25 years? I think because policymakers, the media, the public were really being deceived about what was going on. This is a slide that was shown at an FDA meeting. I was at the FDA meeting representing my organization, Physicians for Responsible Opioid Prescribing. It was a meeting that was convened to talk about putting Vicodin into the Schedule II category, a more restrictive category. Vicodin, and ultimately we were successful, but for many years there was this loophole where a doctor could phone in Vicodin very easily, write 5 months worth refills on the prescription. And so at this meeting, talking about putting it in a more restrictive category, which was clearly clear what it needed to be done, the opposition to making that change, which was the doctor representing a pain organization taking money from drug companies, he showed this slide at the meeting to try and convince the FDA not to put the drug into a more restrictive category. And what's his message? He was telling the FDA, if you put Vicodin in a restrictive category, you're going to be punishing the pain patient for the bad behavior of the drug abusers. It was framed as if we had these two distinct groups: drug abusers who take these drugs for fun and can be harmed by them, pain patients who take them and they're all helped by them, and don't, in your effort to stop the drug abusers, punish the pain patients. That messaging worked for many years, and I think it's the reason we weren't seeing appropriate interventions. Of course, it's not true that we had these two distinct groups, and it isn't true that much less than 1% of patients get addicted. When you look at patients who are on opioids long term, about 40% of them will meet criteria for an opioid use disorder. When you look at patients dying from the prescription opioid overdoses, in one study in Utah, where the health department looked at every single person who had died over a 2-year period of a prescription opioid overdose, the health department got the medical records for every single death in the state from a prescription opioid, and they interviewed next of kin for everybody in the state who had died of a prescription opioid overdose. What they found was that 92% of the patients who died of the overdose from prescription opioids were getting prescriptions from doctors. They weren't buying the pills on the street. So I'm going to start to wrap it up here. I want to make a few final points. This is a graph of the AIDS epidemic. And what you can see is that we peaked with about 45,000 deaths from AIDS in around 94, 95. And then you saw deaths plummet from AIDS. And why did we see deaths plummet? Because we had the introduction of antiretroviral therapy. We had medicines that allowed us to turn HIV from a terminal condition into a chronic condition. Now, I believe we have a medication available to us today for treating opioid addiction that if more patients had access to it, we could see deaths drop in the same way. And the medication I'm talking about is called buprenorphine, and it is an opioid medication. It's different from other opioids. It's a partial agonist. It's quite difficult to overdose on it. It works a little differently. And some of you may be thinking right now that sounds kind of crazy. This doctor's been on stage for the past hour telling us that the way doctors prescribe opioids caused a public health crisis, and now he's standing up there telling us doctors need to prescribe another opioid now to treat opioid addiction as our way out of this, and that doesn't make sense to me. You might be thinking that, and I kind of don't blame you for thinking that, but that is what I'm saying. And I'm not saying that it's better to be on buprenorphine for the rest of your life if you're opioid addicted to be on another opioid. It isn't. It's better if you have any medical problem, if you can be treated or recover from that condition without being stuck on a drug. It's true for diabetes. Type 2 diabetes. If you lose enough weight, if you eat right, you can get off of the insulin. And if you can really do well, you can get off of the pills for your diabetes. And it's true for hypertension as well. There are a lot of conditions. And it's definitely better if you can manage a condition without being on a drugs that have side effects. But a lot of people can't do it. And for opioid addiction, it's certainly true. Buprenorphine, you run out of that medicine, you're feeling sick. You're going into withdrawal. That's not fun. You go on vacation, you lose your prescription, you're in trouble. But a lot of people, it's better if you can recover from your opioid addiction without being on buprenorphine or methadone. But a lot of people can't do it. And if you insist that they recover without medication, we're going to continue to see a very heavy death toll. We want to help people come off of the medication when they're ready and able, but we really have to do a better job of seeing that people who are opioid addicted have access to effective treatment, and that really does right now, unless something better comes along, mean buprenorphine. And when I say that I think that better access to buprenorphine would allow us to see deaths come down, I'm not just speculating. It happened in France. Do you see that black line dropping? That's deaths from heroin overdose in France. And you see the gray line going up, corresponding with that drop? That's prescribing of buprenorphine. In France, buprenorphine was released earlier than it was in the United States, and without the restrictions that we have on it in the United States. And there was a lot of prescribing of it. And it wasn't all a perfectly rosy story. In France, there was a lot of diversion of the buprenorphine onto the street, and it was the type of buprenorphine called Subutex that's easier to inject. And there was a lot of injection use of it in France. But because it's a different molecule, it's very difficult to overdose on it. And so as buprenorphine became available, you saw deaths from heroin overdose plummet in France. And this was a very positive public health success. So I started by saying that 2018 deaths came down a little bit. This is sort of showing you that happening. And I do think that, anybody who tells you they know why we may have rounded the corner on this, some people are saying, well, we did a better job of making naloxone available. Or, people are speculating. And it's probably a combination of things that are the explanation for why we're beginning to do a little bit better in the United States. I believe it was expanding access to naloxone because we can save more people's lives who are overdosing. But we started to do better with naloxone a few years ago. I think more than anything, what explains why we may be doing better is that doctors are prescribing more cautiously, so less patients are overdosing on the pills, and we are beginning to do a better job of seeing that people who are addicted are accessing the right treatments. We just have a very long way to go. Well, thank you for your time.
So, testing, got me? So at this point, are there any questions for Doctor? I guess I'll get my exercise and I'll walk around. You talk about it.
Okay, so we're aggravated with big pharma. We're aggravated with prescribers who don't do good. And in the middle, there's the FDA, who's supposed to be the police and the earth protectors. What is their responsibility?
That's a great question. I really appreciate it because I think we might not have an opioid addiction epidemic today had the FDA done its job properly. If the FDA had done its job properly, had it enforced existing laws that are on the books that it's supposed to enforce, back when Purdue introduced OxyContin in the late 90s, had they enforced the law, they would have told Purdue, great, you've got extended release oxycodone. That's a drug where the benefits outweigh the risks if it's prescribed to people with end-of-life cancer pain. We're going to let you send your sales force to the hospices and the palliative care doctors, but the risks outweigh the benefits when primary care docs are giving it out and dentists are giving it out. We're not going to let you promote for chronic pain or to the family doctors. Had the FDA done that, I don't think we'd have an epidemic today. And by the early 2000s, when it was clear the prescribing was taking off at a rate more than could be clinically needed, and that there was now a public health problem associated with that increase in prescribing, had the FDA started to enforce the law, I don't think the epidemic ever would have gotten as bad as it did. And unfortunately, they have not. And there are different theories as to why they've done such an awful job, but there are some facts. The fact is that the same doctor who approved OxyContin for Purdue Pharma, the FDA official who approved OxyContin, shortly after approving OxyContin, went to take a job working for Purdue Pharma. And we've seen that happen with every head of the FDA analgesic division.
So how
So, well,
sue the big pharma, but not sue?
well, I will say that I believe that the FDA should have done their job properly. There was a lot that the drug companies were doing that FDA isn't able to regulate. They're only allowed to regulate the branded advertising, and much of their campaign was non-branded. And so, I do think that we should have agencies that protect the public from corporations, but the corporations have to behave responsibly. And there was a lot of deception on the part of these companies. They're not allowed to lie to the medical community. So I do think that these companies should be held accountable for their actions. And it's not just the pharmaceutical companies that make the opioids, the companies that distributed them. We have small towns across the country that were flooded with millions of opioid pills coming into pharmacies where they were disappearing out the back door. And the distributors, they could tell, gee, this pharmacy has millions of pills disappearing out the back door. This pharmacy is an outlier. And by law, the distributor was required to let the DEA know and stop giving more pills. They didn't do that. They just kept pumping in the pills because it was profitable for them.
Mine's kind of more of a statement. I think we forget about our past. We look at where we are now, and we forget about our past. We had opium dens back in the 1800s. Opium. It's still opium. It's still opium. People were addicted to it then. They were addicted to a lot of it. It doesn't make any difference. The form it is. They thought, well, it's pill. It's not going to be the same effect it affected them back then. I can remember, and I'm older, but in the 60s, I had a girlfriend of mine, two girlfriends of mine, whose parents were addicted, and they went to 3 different doctors a month to get the pills. Okay? So what was supposed to be for a month, they just went to another doctor and got the pills. Well, I have a friend now that goes to Louisiana, Texas, and Oklahoma. Okay? So there's got to be a way, and she's long-term, 20 years taking these pills. You just can't take them away from her now. I mean, you can't do that, to her body. But there's got to be a way that the doctors can see, to pull up and see who's on what, no matter where they go. Okay?
Yeah. So you've made.
Because she goes to 3 different states to get these drugs.
So you've made 2 really good points, and I agree with you on both. Your first point was that we forget is absolutely right. And yes, there were opium dens, but we had a very severe opioid addiction epidemic in the United States in the late 1800s. And many people will may know from history books about Civil War soldiers getting addicted to morphine, but that epidemic was actually even worse for middle-class women. Middle-aged, middle-class women were getting addicted to morphine products, and many doctors in the late 1800s, early 1900s, they were called quack doctors. They had as the business model for their practice patients who would come in for their morphine injections, and ultimately, we learned, and the medical community learned, and by the early 1900s, aggressive opioid, a lot of these quack doctors were themselves addicted. By the early 1900s, by 1920, aggressive opioid prescribing in the medical community was associated with really bad medical care. And of course, what we had happen in the 1990s was, there had been a lot of time and doctors were told you had it all wrong. But yes, and if you think about the crack cocaine epidemic and how addiction epidemics come to an end, they come to an end when the public begins to really learn. And clearly when we forget, we can get other epidemics. with regard to prescription drug monitoring programs, a doctor can go online and see what a patient is getting prescribed, and they'll see within their state if a patient is visiting multiple prescribers. And some states have interstate data sharing, but many don't. And there should be a national, that would be very helpful. Yes. I don't think Louisiana has that, but some states have passed laws making doctors check that they do. You're required to check it before you write the prescription, or you're required to be registered to be able to check it? That's good. How long has that been in place here? Year and a half, that's excellent. Not only does that help a doctor identify who might be visiting multiple prescribers, but the extra work it takes to take a peek, even though it's a couple extra minutes, reduces the casual prescribing so that, yeah. Oh, that's good. Oh, that's good. That's very good. Yes.
My question is in regards to the treatment for these patients. What I see is patients who attempt to go to a primary care physician and they get turned away because you're required to tell them what medications you're on. And if they tell them that they're on Suboxone or methadone or suboxone or those types of medications, and then the doctors turn them away because they don't want to deal with those patients. What's being done to educate them? Because these patients are now going to behavioral health centers where they're spending $400,000 a month out of pocket to get treatment, and instead of being able to go to their insurance company and back to doctors.
Yeah, I mean, I appreciate the question. I mean, I think if there was better access, particularly to buprenorphine, I think we'd see deaths plummet. And one of the real problems here is that doctors are not allowed to prescribe buprenorphine for opioid addiction unless they've taken an 8-hour training course. And for nurse practitioners and physician's assistants, it's a 24-hour of training before they're allowed to write the prescription. Keep in mind that any doctor who wants to prescribe OxyContin doesn't have to take any special training. Some states have come up with a little bit of training, but there's no federal requirement. And you can prescribe OxyContin to as many patients as you want, but for buprenorphine, there's a cap on the number of patients you can treat, and doctors have to take special training. And so what that means is that 95% of the doctors in the United States, primary care doctors, have not taken this training. And a lot of doctors would say, why would I want to take an 8-hour training course to treat addicts? They have an idea in their mind of what they think these patients are like. They don't recognize some of their own patients are addicted, and maybe even because of their own prescribing. So a lot of these doctors have never taken the training. So a patient who's addicted, who might have the courage to finally tell their primary care doctor, I want you to know I've been struggling with my addiction to opioids, there's a 95% chance that that doctor says, well, you know, I've heard about this medicine, but I can't prescribe it. I'll have to find someone to send you. And because there are so few doctors doing this, the doctors that are doing this, they can name their price. A lot of the doctors who are doing this will say they don't want to participate in any of the managed care plans because it's a lot of extra paperwork and the reimbursement rate is really low. And so they'll tell the patient, look, I don't take insurance for this. I'll give you a receipt. If you've got out-of-network benefits, good luck. Try to get reimbursed from your insurance company. And so patients with Medicaid and even patients with really good commercial insurance, their insurance will pay for the prescription when they get to the pharmacy, but they often have to pay out of their own pocket for the doctor. And if, you know, people who are opioid addicted, when they wake up in the morning, they're going to have opioids right by the bedside, whether it's prescription opioids or heroin, because pretty soon they're going to be feeling sick. And if you know you're going to be sick and you've got $10 in your pocket and you know where you can buy a bag of dope, but to find a doctor who's going to treat you is really expensive and complicated, people are just going to keep using. And so we really do have to fix that. And that really also, I think, falls on the federal government to ease a lot of these restrictions. There should be no 8-hour training requirement. Doctors, NPs, PAs should be allowed to treat opioid addiction the way they treat other conditions. trying to get insurance companies to pay more money for.
Like having a government regulation where big farmers can't continue to make the giant blockbuster bucks on it.
I mean, I think we need a lot better regulation on drug companies, just like drug pricing is an issue. And unfortunately, pharmaceutical companies have tremendous influence in Washington on both political parties. And so it makes it very difficult to see any kind of reforms. But there, just another thing that you didn't see ads on television for prescription opioids, but there are a lot of ads on television for drugs that sort of foster this culture in the United States of a pill for every ill. And, and just if people who visit the United States from other countries and they watch a little television here and they see these ads on TV, ask your doctor for, they think we're crazy. And why would that even be allowed? And it's because you don't have any members of Congress saying let's get rid of those ads for drugs on television. The drug companies have too much influence in Washington.
Would they fight the easing of relaxation requirements for the epinephrine?
Now that they probably wouldn't fight. That actually, believe it or not, fighting the easing of those restrictions, that's the methadone maintenance industry. Methadone maintenance programs see buprenorphine as competition, so they advocated for a lot of the restrictions on. Why is a patient going to line up at a methadone clinic every day if they can see a doctor once a month for buprenorphine? So actually, that was methadone maintenance industry, and there was the manufacturer of the methadone that they dispense, Mallinckrodt, was behind some of that. So yeah, there was a pharmaceutical company. I think I'm going to need to stop now. So thank you all for your time.